Well, good morning, everyone. Tanner and I are really glad to be here with you today. I know we speak for all of Dry Creek when we say we're really lucky to be part of such a great group. We learn from you guys every week, and it's really fun to be here. So, our presentation today we titled "Sticks and Stones May Break Our Bones, but what about the words our patients hear?" So, we want to talk today a little bit about some of the myths and misinformation that are out there that patients might hear from social media, from their friends and neighbors, or maybe even perhaps in our offices that lead them to have fear of movement or anxiety with respect to loading their bodies. This piggybacks on some of the conversations that we've had in here recently. Brad presented on the deadlift dilemma recently. Patients are afraid to bend over and pick up stuff sometimes. John and I recorded a conversation a while back about patients having a lot of fear about popping their hardware out after they have surgery when they come to therapy with just some small movement. So very generally, what are some of the things you guys see in your clinics or in your practices that patients tell you that they're afraid to do? Robert, what comes through your office? What are patients kind of leery of?
I had a guy who had, in his mid-20s, and he was 40 by the time he came to see me, and he told me that he had a doctor told him he should never lift more than 50 pounds for the rest of his life.
Yeah.
I'm like, well, but he still run and played basketball, but for some reason 50 pounds was this magic number. So he didn't pick anything up heavy, and I'm like, oh my gosh, geez. Like, and of course there's a whole host of problems that were downstream from that 20 years later.
Right. So we've all heard it. There's things out there all over the place that patients get really nervous about doing. And that can be a problem because that can lead to them being inactive, to becoming sedentary, getting weak and becoming more fragile. And so their functionality and maybe their things they enjoy in life start kind of going downhill after that. So early in my career, I know neutral spine mechanics were a big thing in PT. We had to have everybody be neutral all the time and protect their back from everything they did. And I don't know that we really need to be neutral all the time. So let's look at a couple of things from social media that patients might see.
If you want to pay attention to some of the messaging that you would think maybe a patient would pick up from this if they had specifically low back pain.
Exercises for back pain is crunchies. Don't do crunchies.
Let's call them crunchies.
Worst stretches for back pain is the seated rotation stretch. Herniated discs, bulging discs, degenerated discs do not like rotation. The biggest mistakes people make when they have a herniated disc is they bend using their spine. Geez, you have to bend using your hip, but what they do is
Wait for it.
Stop being a spine bender.
Look at that face. Stop being a spine bender.
Dang it.
Right? Or a twister. Right? So I'm going to give this guy the benefit of the doubt at the beginning here. On one hand, for someone with an acute low back pain that's got a really maybe hot disc that's having a hard time moving, maybe staying away from crunchies or bending or twisting is going to be beneficial for the acute phase, right? So I like to use the analogy of salt or lemon in a wound, right? So, for example, those are not inherently bad things, right? But if, for example, if you have a paper cut and you put a little lemon in there, how's that going to feel? Not very good, right? So taking these activities away, maybe not bending as much, maybe hinging through your hips for an acute period, may be very beneficial for someone with acute low back pain. But as that wound starts to heal, we need to start exploring these movements again and reintroducing them.
This is why you need to be careful with back pain advice on social media.
You want to know the fastest way to get rid of pain in your lower back? The fastest way to do it is by shaking.
That idea tells me he's never actually had acute back pain, but I
You shake, exhale through your nose. Do it for about 45 seconds to 60 seconds.
60 seconds? Yeah, clearly never had acute back pain.
Should we all just try that?
Yeah.
You can demonstrate for us.
You
If
wanna
you'd like.
10 seconds worth of just...
I get pretty leery whenever I see a video like this that tout something as kind of a quick fix or a be-all end-all for something like especially back pain. There are no quick fixes like that. And we have power and opportunity to help patients understand that this is probably not the right thing to do. Yeah.
I think both these videos really emphasize the importance of the experts, all of us, being on these platforms, where people can go and find good information rather than the stuff that's out there.
Yeah.
You know, it's so hard. I think all of us can agree that social media is difficult. You know, there's not one end-all be-all exercise. There's not one thing that you can do. We have to have disclaimers attached to what we say. But at the same time, we have to be the trusted source where people come.
Yeah.
Or they're going to go to these sources. And you can imagine as a patient, like, how confusing is this?
Yeah.
Like, we can't bend our spines. Like, what in the world? You know, what is the spine for if you can't bend it? But
Right.
Spot on.
We really got to emphasize, like, this is the importance of being on the platforms that we need to be on.
Exactly. You do a great job example of that. And those with Summit, just amazing. The stuff you do put out on social media is just great. So, but like Brad said, our spines were meant to bend. They were meant to twist, right? When someone learns stuff like this and they don't know anything about this, they'll go into a phase where maybe they're walking around like a robot, right? And fearful and very protective, right? When you go tie your shoe, it shouldn't look like this, right? It should be free. Your spines are meant to move, and that's what we need to teach our patients.
So these are some social media examples. Let's talk about one that actually happened in a doctor's clinic. Sorry. Ooh. There we go.
So this is a patient case. We've got a 35-year-old male, 2 weeks after a back tweak while playing basketball. He had some severe intensifying lower back pain and also developed a significant lateral shift. So we actually sent this picture of this MRI and some just little bit of information about this patient over to Tyler. And he gave us just a little splia. We asked him what he would tell this patient with that limited information. Tyler, I wonder if you could share that with us.
Well, first and foremost, that's the worst spine MRI I've ever seen. You know, I looked at this and I thought, well, his alignment's intact. He's got good lumbar lordosis. There's maybe some mild to moderate degenerative disc disease at the most common levels, L4-5, L5S1. There are some disc bulges, so if there was any radicular symptoms, I would definitely want to take a close look at the axial slices to make sure no nerves were being impinged. But otherwise, I'm offering this guy all the reassurance. Like, your spine actually looks stable. There's definitely probably a source of your pain, but nothing we need to worry about too much other than treating what's going on right now.
Perfect. That's exactly what we want to hear, right? Reassuring them that this doesn't look like a serious thing right now, and we'll watch your symptoms and keep you active, right? Unfortunately, this is not the advice that this patient got. Scott, I don't know if you could tell us a little bit more about whose this MRI is.
Yeah, this is actually me. I was 35 years old when this got taken, and was a kind of a weekend warrior basketball player. Had a series of tweaks in my back, and one day this just got to be really, really bad, and I developed this pretty significant shift, and I was struggling. It was hard. I was working with an orthopedic spine specialist, and he told me that my back looked like a 75 or 80-year-old man.
There it is.
It happens all the time. I had that patient yesterday. I was 25, and they told me I looked like I was 60. So even as a PT, that hit me pretty hard. I knew stuff about PT and rehab, but nonetheless, the pain I was in and that message of like, you're old, started to make me think, am I going to recover from this stuff? You know, what 80-year-old is out kicking a soccer ball with his kids or doing heavy yard work or even working? You know, I was thinking about my job. So I had some seeds of doubt planted in my head, and it was definitely a hard time. And that message and that pain really added to it. But all along, I had to make some adaptations. I tried to stay at work, even with my lateral shift. My friends at work would tease me all the time because I would say, hey, am I still shifted? And they'd be like, yeah, you are. So that finally started to get better and went away, and the pain went away, and I got a little more confident and got out and started doing some jogging and kind of got back to life. So time passed. That was probably a good 8 to 10 weeks of misery. And I avoided surgery, which was good, and was able to get back to some stuff. The next year, I I was able to do an obstacle race. This is from something called the Warrior Dash. You can see that giant cargo net in the background. There was tons of climbing and lifting and carrying and squatting and crawling, and had to leap a series of fires at the end, so it was pretty cool. So I made a good recovery and actually got back to doing things. So I have some ability to relate to my patients and kind of tell them about my experience, and that's really come into play a lot with helping them hopefully feel more comfortable going forward.
I want to read this quote. It's by Rudyard Kipling. He was an English writer. Shared this quote at a lunch of surgeons in 1923. It says, "Words are of course the most powerful drug used by mankind. Not only do words infect, ergotize, narcotize, and paralyze, but they enter into and color the minutest cells of the brain." So, very powerful quote there. Just helps us realize that words are very powerful. They can shape our actions, our thoughts, and even affect our brains to be able to change our behaviors, right? And hopefully that's for the good when our patients leave our clinics. So even those specifically with low back pain, they've shown that those that have a poor belief of their back have long-term effects of disability and pain. So think about the words that you use with your patients, and hopefully that is a positive thing that they walk out of your clinic with. It's going to affect their behaviors and keep them active, right? And not keep them from doing things. So what is that responsibility that we have as healthcare providers? That is to be able to bridge that gap between myth and fact and be able to teach our patients and help them know that they're resilient, robust and strong and adaptable, right? So I wanted to bring this discussion up to the group here. Patient walks into our clinic. I'm sure everyone has had this, as if you're a provider. Tells you some poor belief, such as, well, I've got a disc herniation and that's why I'm having back pain, right? How do we approach this with our patients? How do we teach them and educate them? I don't think it's going to go super well if you walk in and you say, okay, well, you're wrong. This is not the reason and this is what's right, right? That's a hard conversation. How do you in this room handle those situations? John?
We mentioned it before, but virtually everybody has findings on their MRI. So that's just normal to have some little bit of degeneration. And then most of the things that need treatment can be treated. So it's not like it's some lasting forever problem. There's lots of ways to manage and treat, specifically with the spine, but I think with all of the other joints. So it's a dual message, right? It's not as bad as they might perceive it to be, and normalize it. Yeah. And then there's lots of things that can be done, most of which doesn't involve some invasive surgery that is going to be a lengthy recovery.
Yeah, exactly. I love that. Carolyn?
I think patients are coming to a specialist for your knowledge in that specialty, right? So I typically will say, in my experience, this is what I've seen.
Perfect.
Right? So it's a way of not saying like, you may have heard stuff from everywhere else, but I'm just telling you like what we see here. So in my experience, a patient like this is of course, maybe this. And their response to that depends on how tightly they're holding to their prior preconceived notions, right? And sometimes maybe all you can do is just present it the first time. Maybe they're gonna have to hear it a few times from a few different people. But I agree with you, like being forceful and like definitive is not usually met well.
Exactly.
Yeah.
Yeah,
I just want to just build on what Carolyn said, because it's amazing. And people will come to you and they've already have, my neighbor or my brother or whatever already had this procedure and they told me this is how it's going to go, and I know this is what's going to happen, and I love that based on my experience. The second phrasing that I use fits that is I'll say, I hear those stories, but that's not been my experience. Right? My experience in my clinical practice is these things go a pretty predictable pathway, and maybe we need to intervene medically, maybe we don't. But I can tell you that based on my experience, the types of things that we have seen and done, this is typically how it goes. Now other people may be that, right? And I also like to point out that oftentimes the people making the most noise on social media are outliers. I mean, they are unhappy, absolutely unhappy, and it's unfortunate, but not every back pain leads to you being in a wheelchair just because this one person who's really, really unhappy about being in a wheelchair, who probably had a catastrophic injury to begin with, right, is saying that I'll avoid back surgery or jump up and down. Like, those are severe outliers.
Yep.
Right? We have to take a look at what the data says and then bring in research, right? Bring in the research, like, well, the current research shows that these are the outcomes that you can expect.
And what I like to do is I'll say, I'd love to, would you be okay with me teaching you about what I know about, for example, disc herniations, right? And usually they'll take that a lot better, right? Ashley, were you raising your hand?
Yeah, I'd say one of the most common myths that I hear is, or kickback I get, is not to ever squat with your knee over your toe.
Good.
And a lot of times people are like, that's just what I've always heard, that's what I've always done, but I always tie it back to function. So when you go downstairs, your knee's going over your toe. If you're running, your knee's going to go over your toe. Snowboarding. So a lot of times if you tie it back to that function, it's like, why wouldn't you train that if you're doing that every day?
Yep. And now, like Robert said, we're going to get into the research and share some things about what that says and what we can empower our patients and educate them about.
So we want to reframe a couple different things. We picked 3 things today that we'd love to kind of reframe in a patient's mind as to what they know or feel about different things. So the first is around kind of the nature and structure of a spinal disc. Alex, will you tell us a little bit about what a disc is like in surgery? Like, what does it feel like? How does it respond? What's its nature?
Yeah, I wish everybody could have the experience to actually hold and play with these tissues in person. I know for the most part, everybody that's in medicine, we get a chance to get through anatomy labs, but live tissue is so much different than what you'll see in an anatomy lab. It's actually quite strong and resilient. The way that we have to address these in surgeries is we're using strong tools, knives, cutters, and metal instruments to pull and pry and tug on these things. They're actually quite strong and resilient.
Okay, good. So what I'm hearing you say is that a spinal disc is not like a soft, squishy, delicious jelly donut. Is that true?
True. Yeah.
So if I were to push on a spinal disc, am I going to eject the nucleus out like that? No? No, so
It doesn't look quite that
so I get where the analogy of a spinal disc is like a jelly donut has come from, but really that is a woefully inaccurate analogy. There's no getting away from the narrative of that story that a disc is fragile and that a slight push on it is going to eject our nucleus. So I think we need to teach patients that that spinal discs are tough. They have robustness and they're resilient. Instead of a jelly donut, let's teach them that our discs are more like a truck tire that surrounds gum. So there's something thick in there. It's more able to take on load. And that's so important. Our discs are important. They have to be able to absorb axial load. They're important for stability in the spine, and that helps create our movement that we get to. So discs are tough. We don't need to worry about our jelly donuts exploding with a slight bend over to spit out our toothpaste. Here's what the research shows. So there's a Ruffelli et al. Study in 2023. Discs are highly adaptable and they respond to the forces or loads that we do or do not expose them to. And a couple of studies show that repetitive cyclical loading and lifting will create positive disc adaptations. So we can make these discs become more adaptable and robust, be less fragile, and more resistant to injury down the road.
Next reframe we want to talk about, asymmetries and imbalance are usually normal and in most cases don't require intervention. So by raise of hand, who in here has some asymmetry or imbalance that you know of or have been diagnosed with? Pretty much almost everyone, right? We talked with Jennifer last week about the scoliosis that she has, right? So in physical therapy school, well, I guess I'm going to pick on someone. Actually, Brad and Janaea back there, they both went to physical therapy school with me, and they probably remember this, right? But Brad, how many broken bones do you have? Did you have, right?
Broken 34 bones.
34. right? I was going to say 26, but maybe those were more recent that I didn't remember, right? So do you have any asymmetries?
I'm pretty balanced. I definitely have.
I have a few. So in physical therapy school, one of the first weeks I think it was, we had this class one day, and they told us it was called Naked Day, right? So not what you think it is, right? But well, maybe, right? We came, we were advised to wear the least amount of clothing we could, right? So men were in shorts, and we had to even like tape our shorts all the way up, right? Women were in sports bras and really short shorts, and we stood, and we had up on the board a person that was perfect, right? Perfect asymmetry. Perfect symmetry, right? And we looked at our classmates and we said, okay, let's look at this asymmetry, let's look at this imbalance, right? And we jotted down some things, right? Do you guys remember that? Right? So Brad was a little bit more interesting to look at because he had some of the more asymmetries there, right?
They are observing my gluteal fold.
Yeah, right? So from the beginning, we were ingrained with that picture of a perfect symmetrical spine, right? And we learned how to fix it, how to give interventions to try to help it, right? Even early in my career, I did a lot of that, teaching people about posture and saying, okay, these are bad postures and these are good postures, right? But as we're going to see in a second, the research is not necessarily telling us that, right? So let's go ahead and watch this video. This is an example of how things can go wrong.
I can only train arms due to some muscle imbalance issues. You can see that my left shoulder sits lower than the right.
That's not an imbalance. That's a normal structural asymmetry. We all have them. They're not a problem. Some are beneficial. Trying to fix those would be like trying to stop using your dominant hand or removing the third lobe on your right lung to match the two on your left. An imaginary problem gets bigger when professionals connect imaginary dots to other imaginary problems like this.
Foot turns out, knee falls in, hips tilt, right side shifts forward, torso leans to the left, left rib cage rotates forward, right shoulder rotates forward, right collarbone drops down, left shoulder pulls in and back, rotates internally, left collarbone pulls up.
Ta-da! Now it's a whole body problem. That'll make you feel pretty fragile, which makes you cautious, which makes the whole problem even bigger.
Can't train my chest directly due to some muscle imbalance issues. I haven't done a direct back workout in 9 years.
It's safe to train asymmetrical body parts. Paralympians compete at the highest level with the biggest asymmetries.
That is a great.
Kind of eye-opening, right? I don't know if you saw the counter up there. You could read, but 15 problems that person on that video saw, right? And that can become a whole body problem and make someone become fragile, right? He hasn't done a back workout specifically in 9 years, right? Because he's afraid to train his back, right? So, like I said, as I learned in school, there's a lot of things that we focused on that posture, good posture, bad posture, right? So let's go into the research, and kind of surprising in when I started getting into the research early in my career of what it says, right? So let's start with this first one. It says, systematic review of 54 studies found no association between sagittal spinal curves and pain or disability, right? And we see that there are natural variations in spinal curvatures, and there is no single spinal curvature strongly associated with pain. Next, we hear about anterior pelvic tilts, right? So degree of anterior pelvic tilt or lordosis angle are not related to pain. And even thinking about leg length discrepancies, length or flexibility of the hamstrings, iliopsoas, those kind of things are not related. We don't see in research they're related to pain. And more of the same. Severity of kyphosis cannot be associated with pain. So what does this mean, right? We can even go back to that example of the salt in the wound analogy, right? So some people maybe will sit in a position like this for long hours of the day, right? And maybe that's just putting some salt in the wound and giving them some pain, right? But likely they've been sitting in that position for years and years and not have any pain, right? So we can't necessarily just bring that toward the posture, right? Some of us will fix that posture and we'll say, okay, let's give you some exercises. Let's think about being more upright throughout the day, right? And likely that patient's going to feel better, right? And so a lot of us will say, okay, well, that's the fix, right? That's the cure. We change the posture, right? But as the research shows, it's not necessarily the case, right? Maybe we put them in a different position for a time and the pain got better and that salt came out of the wound a little bit and they feel better, right? So we need to be careful with with our patients to be able to teach them and empower them that these positions are okay. Research shows that you can sit in these positions whenever you want, as long as it's not for too long and throughout the whole day, right? Inactivity is more the issue that we're dealing with. Let's watch this video.
Go ahead. Go ahead.
No, I was just going to say, but if you don't mind going back to the slide, true, they may not be linked to it with research. However, our job as professionals is to pick up on these asymmetries and go, what does this mean?
Mm-hmm.
So sure, you can work on your back with that asymmetry, but I mean, if you have a tight iliopsoas and hamstring, you're at higher risk of creating an injury and problem, right? So the same thing. The biggest misnomer I get in my clinic is, hey, I've got knock knees, so I mean that means there's something wrong with me. Well, no. There's 9 variations of the way your knees can be formatted. However, being knock-kneed puts your patella at risk for issues. Therefore, you have to have a higher propensity to work on your quads and your hamstrings to protect your patella.
Yeah.
So I think we have to make sure that we don't just, oh yeah, asymmetry is normal, it's fine,
Yeah.
we don't do anything about it. We still have to have our heads up. And I think that's the other thing is we can take this communication the opposite way. Maybe if you tell a patient, hey, that's fine, your tight hamstring and iliopsoas isn't a problem. Well, they'll hear that and go, oh, I don't have to ever stretch my hamstrings or iliopsoas, right? So just like you said, words are powerful.
They matter.
In both
Yeah.
directions.
Yep. And that matters for an individual patient cases, right? We see people all the time with these same asymmetries and they don't have any pain, right? But yes, if these people do have pain, we can address these. And like we see that a lot of these issues may not require intervention, right? But definitely, like you said, Todd, that's something that we can't necessarily just brush off, right? But like we said, like we kind of talked about, that can also lead to people to fear, right? If they do know that, oh, okay, well, this is a perfect posture and I have to stay out of this position, right? They can become someone that doesn't get into those positions and limit their activity, right? So let's watch this next video. This is Lamar Gant. He was told not to weight lift at all because he had a severe spinal scoliosis, and he was the first to lift 5 times his body weight. This is Dalton Lacoe. He got diagnosed with Klippel-Feil syndrome. Which is fusion of his upper cervical spine. John could tell us a little more about that. But look at these individuals, right? They've got such big asymmetries, and to see what they're still doing, right? So lesson here is that we're not limited by our diagnoses, right? And in some cases we do need to address those, right? But in most cases, addressing those issues is not necessarily that necessary, and we will hopefully get our patients to learn that they can sit however they want, right? As long as it's not for too long, right? So let's go to the next. Where now? Okay.
We're going to talk a little bit about deadlifting and squatting. Brad handled this pretty well. Obviously, patients are afraid of that in a lot of times, but tends to be one of the things that helps a lot in clinic. Brad, would you agree with that? Like if you get people back to deadlifting, that can be a really excellent form of rehab. So it's something that's on our list. We'll just for time's sake, we'll have to skip through some of these videos here today. And there's great research on that too, that lifting with a flexed spine can actually be a good thing. I've seen the term lift ugly sometimes. Sometimes we have to lift a little bit ugly to kind of make it mimic something that we're going to do in real life. How do we teach people to see that they're resilient? I like the term, the poison's in the dose. Sometimes if exercise is medicine, there has to be a correct dosage for that. We overdose when we do too much too soon after periods of doing too little for too long. So if we can find the right dosage and help people understand what to do, I think we can really get them back. I was going to bring some props in and show how we do a little bit of that in the clinic. You can imagine somebody who has a problem forward bending. We might grab a really big TheraBall and have them hold it, either in a sitting or standing position, and let that guide their range of motion. And when that feels comfortable, then we can decrease the size of the ball or put it out in front of them a little bit more so we can change the leverage they have to deal with. So little teeny nuggets of progression to kind of build functional adaptations in these people. So instead of shaking for back pain, let's teach people to stay active. And like medicine, adjust the dosage to tolerable levels. Try to stay at work, modify the loads, find the most comfortable place to sit, get up and change positions often. Things like that can help us get through. Use symptom modifiers. These could be passive modalities like ice and heat and TENS and manipulation and needles and things like that to turn down the volume of pain. It might even be an active movement that feels good. And then remember time. It's going to take 6 weeks on average for a low back tweak to get better, but maybe even a little longer for a disc herniation or an annular tear or something like that. So take-home message to give to the patients: we're not fragile. We can adapt. Asymmetries are normal, and we don't have to be afraid of still moving even in their presence. And when we're in pain, let's scale down our activities and then we can build them back up. So we don't have jelly donuts for everyone, but there are donuts to grab on the way out the door. So please grab those. Thanks for your participation and great discussion. Thank you.